Okay, hi everybody. So this is going to be a PowerPoint and an instructional lecture on uncomplicated pregnancy. So let's rock and roll. Share my screen. And this is the one. And there it is. And let me move this up here out of the way. Okay, so an uncomplicated healthy pregnancy. As with all of the PowerPoints, there are learning objectives. So we're going to look at anatomy, physiology, and then pathophysiology of pregnancy. How do we take care of clients in the first, second, and third trimester? How do we use clinical judgment to provide care to these clients? Okay. Now, anatomy and physiology changes. So in the female reproductive tract, commonly the woman will have amenorrhea when she's pregnant, and that is no period, right? But sometimes women can have a period. I want to always add a caveat because no two people are exactly alike. So you can have a period and still be pregnant, but typically you do not. And then the smooth muscle of the uterine wall actually starts to engorge because the lining of the endometrium is inside the uterus. That lining starts to thicken because it's preparing for that pregnancy, to support the pregnancy. Hormonal changes, and we're going to talk about the different hormones: estrogen, progesterone, prolactin, human chorionic gonadotropin, that's a mouthful, and your breast and mammary gland changes that will occur. So here are the hormones. Let's talk about them. So HCG, that's the thing we test your urine for when we do a urine pregnancy test. Yep. So it's the basis for pregnancy testing. It's produced by the corpus luteum. That's something that's around the egg, right? And in the early days of pregnancy, if fertilization takes place in a healthy pregnancy, the numbers of HCG double and triple and quadruple like mad fast. Right. Because what that does is that helps get the body, hey, listen, we're pregnant, get ready, right? Until the placenta actually implants and that starts taking care of the baby. Progesterone actually helps establish the placenta, maintains the health of the uterine wall, supports the growth of blood vessels, and prevents mom from having premature contractions. Estrogen promotes the blood vessel growth, also maintains the lining of the uterus, and helps with the baby's organ development. Prolactin, just listen to the name, lactin, lactose milk, stimulates breast growth and the production of new milk ducts in the breast and the production of milk. Relaxin, listen to the name, relaxin, promotes uterine relaxation, cervical softening, and maternal vasodilation. And then we have oxytocin, which stimulates contractions, and that's not supposed to start coming into play until the end, right? So what are the cardiovascular and hematological changes that happen? These things are increased. Women will get more blood volume. You'll actually have more blood because you need it because now you're supporting another life. Heart rate goes up. Clotting factor increases. So there's an increased risk for women that are pregnant to develop a DVT or a blood clot. And there's increased pressure in the lower extremities, which increases the risk for varicose veins. What's decreased? Peripheral vascular resistance will decrease, which means blood pressure will go down. And the blood viscosity. Viscosity is how thick something is. And you think about oil versus water, right? Oil is thick, so it's slower to pour, and water just, so decreased viscosity of the blood. The blood is not as thick, but there's more of it. Musculoskeletal changes when you're pregnant. You ever notice a pregnant lady walks and she's like, oh, especially towards the end of the pregnancy, because she's trying to counterbalance the weight in front, right? So this is the pretty normal curvature of a spine. That's the thoracic curve and that's the lumbar curve. As the fetus grows, do you see what's happening with the curve? It's getting more pronounced, right? So thoracic and lumbar curve increase and you're like front heavy. Here's just some pictures of some abdomens, right? That, who knows what that line is called? Anybody remember the line? Linea nigra, right? That is that dark, hyperpigmented line that usually will run up and down the abdomen, sometimes only from the umbilicus to the mons pubis. Sometimes it runs the whole way. The more melanin you have in your skin, the darker your skin, the darker the line. right? And what are these called? Anybody? Striae, which are stretch marks, right? And that's genetic, just so everybody knows. You can be putting cocoa butter and baby oil and everything else on your belly. If you're going to get them, you're going to get them, sadly. Other changes, respiratory system. So with the respiratory system, you're actually breathing a little deeper and faster. In the beginning, towards the end, because of the pressure of the fetus before that baby lightens or drops, you have a hard time breathing. Moms can be short of breath the last trimester because it's pushing on the diaphragm, right? And you feel like you can't take a breath. GI system, the larger the fetus gets, the slower gastric motility is. In other words, how quickly the food in your stomach actually moves into the intestines. Because of that, heartburn is a problem beginning of pregnancy, first trimester, and last trimester. Usually the one good time is the second trimester, where you feel pretty well, just ignore it. And then your genitourinary system, the first trimester of pregnancy, pee, urinary frequency, very typical. And then also in the last trimester, but for two different reasons. In the last trimester, you're peeing all the time because the fetus is big and pressing on the bladder. So your bladder feels full with a little bit of urine in it. In the beginning, it's because of the hormones, right? Where it's just making you have urinary frequency. So they have discussion questions here, which you can do at the end of the lecture, and this class will do them together later. Physiologic changes during pregnancy and unexpected and uncomfortable changes. Pregnancy can be not fun for some people. So first trimester, right? The focus is prenatal care. The first trimester is when the key elements of the neurological system of this fetus are developing. So if anybody's doing drugs or, drinking or anything, this is when there can really be a problem in the development of that fetus, of the embryo to the fetus, is that first trimester. And a lot of times you don't even know you're pregnant, right? People sometimes 12 weeks, 14 weeks, right? And they don't even know they're pregnant. They're just finding out. Hopefully they weren't out party, because that's a problem. First prenatal visit, we of course want to get the woman's history, right? So, and we're going to do that Nagel's rule, estimate the date of birth. And that's just an estimate because a normal pregnancy is 38 to 42 weeks, typically about 40 weeks. If she uses any substances, hopefully she doesn't. Any STIs, STDs, same thing, sexually transmitted infections or diseases. There's any history of mental health problems, and we'll talk about that later because postpartum, you get a little sad sometimes. Sometimes that can become more than just a little sad. It can become a postpartum psychosis. We'll talk about that later. And heaven forbid partner violence, if there's any abuse going on. Physical examination, so lab tests. They're always going to do a prenatal panel, serum panel. What they're looking for is genetic predispositions, right? They're looking for proteins in the blood that would predispose your fetus to certain hereditary problems. Going to do a urine culture, RH factor screening. They're going to find out what is your blood type and are you RH positive or negative. And a glucose challenge test. Sometimes, if they have reason to, on the first prenatal visit. Sometimes that's a little premature, right? But usually towards the end of the first trimester, beginning of the second trimester, if we suspect gestational diabetes, that glucose challenge test would be done. And then ultrasound, which is a definitive way to say, yep, there's a baby. We see it, right? And chorionic villus sampling is typically only done with high risk, somebody who we believe would have a neural tube deficit or some kind of a problem. That's not a standard that's done. When you look at this picture here, you see the height of the fundus by weeks, right? So this is, again, typical, average. I hate the word normal. So around 12 weeks, right about there, 14 to 16 weeks. By 20 weeks now, it's like, that's the age of viability, by the way. 20 weeks, right? That means that the fetus could hypothetically survive outside of the uterus, right? I mean, it's touch and go, but it is the age of viability. and so on and so forth. Do you see how 36 to 38 weeks is way high and then 40 weeks is lower? And what's that from? Say it. Lightning, that's right. When the baby engages or drops, the fundus actually goes down and mom's like, oh, I can breathe, right? Because it takes all that pressure off of the diaphragm and whatnot. See here. Pregnancy education. How much weight should someone gain? So, and this is a common question, and nutrition. These are very important things. Average weight gain, right? 25 to 30 pounds. And it doesn't matter if you're diabetic or what, because the baby has got to eat, right? And it should be good nutritional food, right? Some people get cravings. That's always fun. I wanted double delights from Dairy Queen with my first pregnancy every day, which is why I got very large. Not good to gain too much weight when you're pregnant. Folic acid is very, very important in neurology. So as far as the neurological development of the embryo and the fetus, if you're trying to get pregnant, the doctor will sometimes tell you, just go ahead and take a folic acid supplement, just to be on the safe side. Nausea, vomiting, and heartburn. And we talked a little about this already. So, these things are not unusual. They happen during the first trimester. Morning sickness. People will feel queasy. Sometimes they'll throw up. Have a cracker before you get out of bed. That'll help. Don't confuse that with hyperemesis gravidarum, which is an extreme of that morning sickness. How are you coping with the pregnancy? That's important. Mental health. So, is it a planned pregnancy? Was it a oopsie-daisy? So there are lots of variables, but the mother's mental health is extremely important. So that's something that we're going to talk to the mom about and, hopefully give her some enlightenment or get her help if she needs help. Exercise. You don't start a new exercise regimen that you've never done when you get pregnant. Now, if you already have you're a runner, let's just say, the most boring exercise in the world, but you're a runner. If you've been doing that consistently, then yeah, you probably can continue that. But you don't say, oh, I'm pregnant, let me go to the gym. If you've never done that before, you don't start a new regimen when you're pregnant. But you do need exercise, right? You do need exercise. Sleep is important. They bring up pets. And one of the key reasons they bring up pets, if she has cats and there's a litter box, pregnant ladies cannot touch a litter box. They shouldn't be playing out in the yard with garden soil, right? They should not be eating uncooked food like, sushi or carpaccio, right? Why? Toxoplasmosis, which if we were to get it not being pregnant, not that big a deal. For a pregnant woman, the fetus can be actually killed from toxoplasmosis. So it's very dangerous. So I'm going to throw that in here. A question that a lot of people ask, can I still have sex when I'm pregnant? Well, yeah, you can. Sometimes towards the end of the pregnancy, it's weird for the guy. And I've heard, expectant fathers go like, I don't want to hit the baby's head or something. So the baby's still in its amniotic sac. And as long as that's intact, you're cool. If the water broke, if the membrane's ruptured, then that's an open route to the baby. So there would be risk of infection. So no at that point. But otherwise, keep having sex. If you want to have sex, it's all good. We put kitty litter here so we know about toxoplasmosis. Travel and vacation or vaccinations. So one of the big problems with travel is the risk of blood clots. So you don't want to go on a long car ride, a long train ride, a long plane ride, right? And not be moving around. Lots of variables based on individuals. So you consult with your physician and you make a decision with your physician or your nurse midwife, right, together. I wouldn't go to a third world country. My niece went to Cambodia. She was not pregnant, but she went to Cambodia and she came back with Giardia, with a bunch of parasites. And she drank bottled water, but still, you're showering with that water. So anyway, you get the point. If you're pregnant, things that are just an annoyance to us can be fatal to the fetus. So you've got to be very careful. Discuss everything with the obstetrician. Don't make any plans. incompatibility. Some people were having some trouble with this, but let's go over it just to make sure that everybody gets it. What is RH? The RH factor, right? The RH factor is in your blood and you either have it or you don't. Doesn't matter what your ABO blood type is. You can be A, B, AB, or O. They're your blood types. But all of them are either positive or negative. They either have the RH factor or they don't have the RH factor. If the woman is RH negative, the baby could be negative, could be positive, right? It's a 50-50. We don't know. There's an exchange of blood between the mom and the baby. If the baby's negative, no big deal. If some of the baby's negative blood and the mom's negative blood mix, no harm, no foul. If the baby's positive, this is where the problem arises. The baby's positive blood will backflow into mom's bloodstream. If mom's immune system is working right the way it's supposed to, it's going to see that positive blood as an invader, as a pathogen, as something bad. And mom will build up antibodies to that positive blood. Not an issue for that pregnancy. She'll have that baby, no problem. But if she gets pregnant again, the subsequent baby, if it's positive, her antibodies in her immune system will attack that embryo/fetus and try to kill it. So we give a shot of Rogam. Rogam prevents mom's immune system from making antibodies against that positive blood. And mom will get that shot. If she's negative, she's going to get that shot between 26 and 28 weeks gestation. And after the baby's born, if the baby's positive, she'll get a second shot within 72 hours after she has the baby. If the baby's negative, then she doesn't need the second shot. Right? Okay. So, and you know, it's a problem. Like I said, it doesn't affect the mom so much as it affects the subsequent pregnancies. Because if mom didn't get the Rogam shot and had an RH positive baby, like I said, that's RH incompatibility, and that fetus is at a huge risk for birth defects, for damage, even death, right? Because mom's antibodies are going to be attacking it, trying to get rid of it. And immunosuppression, which is dangerous. Whenever you suppress someone's immune response, you put them at risk for infection and that type of thing, right? So that's a dangerous thing. The nursing process. Every question that you're going to get, right? And especially those case study questions on the next generation NCLEX. What the Board of Nursing, what the NCSBN does is they have a method of what they expect from you as students. And they expect that you can recognize cues, in other words, assess a patient or a situation, that you can analyze those cues, that's analysis. These are the types of questions. That you can prioritize the cues, right? So that you know, like, what do I do first? Or who do I see first? That you can come up with some sort of a solution that's nursing based, because most of the questions, the answer won't be call the doctor. Sometimes it is, but more often than not, it's what is a nursing thing that you can do. Patients short of breath, raise the head of the bed, right? So that was an assessment, an analysis, and an intervention all in one. I see the patient short of breath, they're lying supine. I know that that's no good for them. I'm going to raise the head of the bed. Boom. Nursing intervention. And the action is the implementation. And then, did it work? Did what I do work? Is her breathing better? Right. So that's the nursing process. Okay. Pregnancy, second trimester, prenatal visits, physical exams. They're going to measure the fundus just to make sure that that fetus is developing the way it should be. Laboratory testing, sometimes diagnostic testing, sometimes amniocentesis, right? Which we talked a little bit about, which we're looking for chromosomal abnormalities like trisomy 21, which is Down syndrome, for example, cystic fibrosis, those types of things. Especially if mom is considered a geriatric or a high-risk pregnancy. Believe it or not, geriatric used to be over 35. Now they're saying, you know, 35 is kind of on the border. If you're over 40, you're definitely a geriatric. maternity patient, right? You're older. The eggs that women have are the eggs that they have from the time they're born, right? Limited number, whatever you got is what you've got. They reach puberty and then the eggs start to mature. So all the real fresh eggs are the ones that are popping out when you're 13, 14, 15, 20s, even like late 20s, early 30s. So by the time you get to late 30s and 40, sometimes the eggs that are left aren't that great. Not always, but sometimes. So there's a bit of caution that's exercised with a geriatric maternity patient. Pregnancy care in the second trimester and education. What are normal changes or what are changes that are worrisome? Something where you'd go, oh, that's not good. Some women are real uncomfortable with the way they look when they're pregnant. Some women embrace it and they wear like half crop shirts and the belly hanging. I mean, whatever floats your boat, but it's a natural process. So you don't want to be uncomfortable with your body. Going to start feeling that baby move. That's the quickening that we feel sometime around 16 to 20 weeks earlier with subsequent pregnancies. You can still have sex, right? Absolutely. It might be uncomfortable. You might want to try different positions because, the belly's in the way. Not going to do missionary. It's going to be difficult. Same thing with the travel and vaccines, even more so now. You don't want to be going anywhere where you're going to be putting yourself at risk for either a disease, right? And as far as vaccinations are concerned, when you are pregnant, you cannot receive any vaccines that are live. And that's important. So the 5 that are live is MMR, varicella, and then the herpes zoster, right? So you cannot get them when you're pregnant because they're giving you a little bit of a live virus and the baby can actually get the disease. And then you've got a big problem, right? So no live vaccines. Can you get a flu shot when you're pregnant? You absolutely should get a flu shot when you're pregnant, right? You don't want to get the flu. Braxton Hicks contractions. What is the difference between Braxton Hicks contractions and real labor contractions? Anybody want to try that one? Go ahead, Carrie. Right. So they're not making you efface or dilate. They're practice contractions. So you feel the contraction, but it's not really doing anything just yet, right? It's practice. So those are Braxton Hicks. But sometimes they can feel real. And a lot of times at the end of pregnancy, women are running back and forth to the hospital. I think I'm in labor. No, you're not. Go home. I think I'm in labor. No, you're not. Go home. I want to be in labor, but you're not. Go home. So, that's a problem sometimes. But you need those Braxton Hicks because it's preparing your body for the real deal. So again, the same kinds of things, the cue, the assessment, the analysis, the planning, the implementation, and then the evaluation, right? Third trimester, she's big. Prenatal care, very important. You're going to have more frequent visits with your OBGYN. Physical exams now. For the second trimester, they're not usually checking you for dilation or effacement, right? They're basically just measuring the fundus, getting your weight, checking your blood pressure. But now they're going to start doing vaginal exams to see anything happening, right? Is she starting to efface or dilate? Sometimes there's lab testing in the last trimester. It's not frequent. The one thing they will do is the group beta streptococcus test. And that consists of a vaginal swab culture and a rectal swab and a culture. Group B strep, a lot of people have it. They don't even know they have it because there's not a symptom that goes along with it. Not a problem. But if you're pregnant, you have a vaginal delivery and that group B strep is in that vaginal canal while the baby's passing through. That can be very, very bad to the point of like severe harm. I have a friend, their baby had a stroke like an hour or two after birth, after delivery, because of group B strep. Most states require group beta strep testing done for all mothers that are in that last trimester, like where delivery is coming. And post-term pregnancy. A post-term pregnancy is when you're more than 42 weeks, right? It's because pregnancy, like I said, 38 to 42 weeks, right? Typically 40. If you're going to 41 and 42 weeks, things are going to start happening that shouldn't be happening. The placenta is not going to be as effective as it was, right? Because you're not meant to carry that baby for longer than that period of time. So oftentimes, if there's nothing going on as far as labor or effacement or dilation, then a decision has to be made. Sometimes they'll induce the mother. In other words, we'll give her an IV of medication to try to like push her along and make labor move a little quicker. With inducement comes usually stronger contractions, right? So it can be a little more uncomfortable. Or sometimes the baby's breech in the wrong position or something else is going on and we have to schedule a cesarean, right? But post-term pregnancy can be dangerous because the things that are keeping the baby safe up until now are going to start breaking down. They're not meant to continue for that period of time. Body changes and discomfort. So we talked about that curve, you know, when that fetus, and depending on how big the fetus is, I told you guys the other day, my daughter had kids that were like 9, 15, the first one. The third one was 11 something pounds at birth. And typically that's considered a macrosomic baby. Macrosomia is a large for gestational age baby, and they're usually the product of gestational diabetic mothers, but not always. She just had big babies, right? So you're really backwards, you know, when you're trying to compensate for all that weight. The baby should be moving like crazy. And typically the movement you will feel the minute that the mom lies down at night, because all day you're moving around, you're rocking the baby. The minute you're still, baby wakes up and will start kicking and rolling and moving around and doing all kinds of stuff. Same thing with travel and vaccines, like we talked about, dangerous. The closer you get to that 38, 40 weeks, the more we would be cautious before letting you, you know, go take a long plane flight. I mean, you might go into labor on the plane. You don't want that. And we're going to start looking for manifestations early. You know, are you starting to efface? That's the thinning of the cervix. Is that starting to happen? Dilation occur? Anything going on? And yes, you can still have sex up until the rupture of the membranes. Then nothing goes in the vajayjay after the rupture of membranes. Okay, now we're going to talk about a birth plan, which you want to share with your healthcare provider. Some people have something called a doula, which is just somebody who read a book or something, and then they're like your coach kind of a thing. It's nice if you don't have a significant other that can be with you, right? Oftentimes they'll let only one person in. Depends on the hospital, depends on the doc, lots of variables. Sometimes they'll let 2 people in when you're having the baby. That's why you want to go over your birth plan before you go into labor so that everybody's on the same page and they know what you want and you know what you can and can't do, right? During the labor process, questions that the healthcare provider might ask you. Labor assistive devices. Here we're talking about a vacuum assisted delivery or forceps. So, especially with first-time moms, sometimes the pushing does not come as a second nature. Sometimes it just doesn't. And when labor's taken a while and mom's pushing, sometimes the doctor can help with forceps. Forceps look like big salad tongs, real long salad tongs. 2 pieces, one goes in, the other one goes in the vajayjay, snap them together. They go around the infant's head gently, right? We don't rip the head out, but with a contraction and with fundal pressure, not like that story that we read earlier, we can ease the baby out, help mom along. If her pushes are not enough, you know. Vacuum assisted, I'm gonna have to look it up and see if they even use that anymore, but that's just what the name implies. It's like a little suction cup that goes here because it can't go here because that's one of the fontanelles, the soft spots. Goes here on the baby's head and it actually helps fundal pressure and pull the baby out if mom's having a hard time. If the baby's in distress, we're calling it a day and boom, emergency section, right? We're not going to mess around or decapitate babies. Requests for labor environment. Now, like when I had my kids, but now people have like, I want to hear Van Halen playing while I'm giving birth or whatever. You know, you can make requests like that. They have birthing rooms in birthing facilities that look kind of like a bedroom. They don't look like a sterile hospital environment, but you're still in a hospital. God forbid something goes wrong, right? Who's going to cut the cord, right? recording the birth, those kinds of things. These are all things that you want to talk about before you're in labor. And skin to skin contact and breastfeeding and care of the newborn. When I had my kids, there were no breastfeeding Nazis coming into my room going, what do you mean you're not breastfeeding? Breastfeeding is better for the newborn. There is no arguing that, right? In general terms, because the colostrum that comes out first, that yellow kind of stuff, is loaded with protein and nutrients. And then the breast milk, I mean, it's ready-made, right? It's easier and it's good for the baby. But some people don't want to breastfeed, and you can't make somebody. So that's the mom's choice, right? Sometimes people will try it and be unsuccessful for whatever reason. Or sometimes you have people like me that, I was very good when I was pregnant. I didn't smoke cigarettes. I didn't drink coffee. I didn't use sweet and low, no soda. I ate a lot. But as soon as I had the baby, I felt like, 9 months, I've been really good. That's enough. So if you're going to be smoking, you don't want to be breastfeeding. If you're going to be, drinking a lot of soda or things that we know are not good for us, that passes through your breast milk. Drugs pass through the breast milk. Anything that mom puts in her mouth is going to potentially pass through that breast milk. So that's a decision that mom has to make. Skin to skin contact. Once that neonate is born, the first thing they're going to do is suction, and then they're going to dry the baby off so the baby doesn't lose heat. But it's important for that baby, naked baby, on mom's naked chest, a blanket over, right? Skin to skin contact, that's that bonding. And then to make sure, if you're a younger, new mom, do you understand how to care for the baby? Do you have a support system? Do you have a mom or an aunt or somebody that can help teach you? Or do you want to go to they have classes, not just birthing classes, but care of newborn classes, teach you how to diaper, how to swaddle, teach you, about feeding. They have the LaLeche League, which is about breastfeeding assistance, if you're having difficulty with that. So there's help out there for all kinds of issues with the neonate. And so here are these discussion questions. What are you going to include in that birth plan? Everything that you want to make sure that it's reasonable, right? Some people want to have babies at home or in a different environment than a hospital environment. The only thing, and this is only my humble opinion, does not reflect the opinion of AHG Schools nor any of its affiliates. There's my disclaimer. If something goes wrong, it could be bad if you're not in a hospital. That's the only worrisome thing about not having a baby in a hospital. And sometimes time is critical. And however long it's going to take to get mom and baby to a hospital could be the difference between life or death. So that's the only reason I kind of go, I don't do that. But you do whatever you want. And the nurse is going to work closely with the patient to help come up with that birth plan that's going to work for everybody, that everybody's going to be happy with, hopefully. And the cues and all that stuff that we already talked about. And that's the end of this one. The next one's going to be about assessing the newborn too and taking care of mom. All right. Hope you had fun. Peace out.